now if you're holding the brakes.
Hello? Hello? Somebody's there? Hi Uli, kannst du mich hören? Mach mal dein Mikro weg oder kannst du das nicht selber machen? Doch jetzt, kannst du mich hören?
Ja, jetzt. Jetzt geht's.
Kannst du das selber machen oder kann ich das nur machen?
Ich glaube, du kannst das nur machen.
Klick mal rauf bei dir. Kannst du es selber an und aus? Ja, jetzt bist du weg. Mach wieder an. Du kannst dich nur rausbeamen.
Ja, genau.
Damit keiner dazwischen quatschen kann, wenn ich rede.
Genau. Du hast alle Macht.
Sehr gut, sehr gut. Das ist schön. Jetzt müssen wir mal gucken, ob die anderen schon da sind. Das weiß ich natürlich nicht. Die chinesischen Schriftzeichen oder japanischen. Ja. Ne, die haben jetzt parallel dieses Spine-Meeting, sonst haben die das immer alles gemanagt.
Ah, okay.
Der Salman, der hat heute diese große Session von ihrem Spine-Kongress.
Ach so.
Deswegen können die uns nicht richtig helfen.
Naja, kriegen wir schon hin.
Aber Imad wollte uns unterstützen. Imad, bist du irgendwo there? Are you there? Ja, keine Ahnung.
Marc ist derjenige, der das immer für Salman gemacht hat?
Ja.
Ah, okay.
Samuel, welcome. Ja. Chandra is coming. Sie machen so einen Warteraum. Ich kann die dann reinlassen oder auch nicht. Chandra, are you with us now? I have to unmute you. Chandra, welcome.
Welcome.
Nice to see you, Henry and Ulrich.
Yeah,
Nice to see you.
now it's working. Very good.
It's raining very heavily in Mumbai today.
Really? Too
Yeah.
much, or is it good?
Well, we have had our share of rain, so now it is probably not so important. But
Okay.
Bombay is completely different in rainy season compared to rest of the year. And this
Yeah.
year, because of the pandemic, it is.
Hello, Roberto.
Roberto. Hi.
Hi.
So I can unmute you and I can give you the voice. That's good.
You
Suresh,
have all the controls.
yeah, should we give Suresh the voice or not?
No, let Suresh come in.
I think it's
You
enough
have
when everybody can see him. It's okay.
Yeah, you have a picture.
Welcome.
Thank you.
So I don't know how it's done with the multiple choice questions.
Have you sent Ulrich?
We have all three sent the questions and I send it to Imad. I write him a message.
That's how, yeah, that's how we do it every time.
Yeah. Pre and post.
Pre and post, yes.
Is Salman joining us today or is he busy?
No, he cannot.
He has another webinar, I think, spinal webinar or something.
Yes, he
There
has
is
a
a
congress.
virtual
Yeah.
spine meeting going right.
At the same time, yeah. Hi, Ulrich.
Hi, how are you?
Good to see you.
Good to see you.
Right. Okay.
You were supposed to be here next week, Ulrich.
Yeah,
For that.
how could that happen?
Yes. We were
Can you
supposed
believe
to be together on Thursday and Friday.
Yes, yes, it would have been wonderful. Now we don't have any traveling this year, almost any.
Yeah, I don't know. I mean, they are starting international travel from here to Germany on some in a week's time, I think, 10 days time.
Okay. Wow.
Is it really a good idea to travel?
Yeah.
Have you traveled at all, Henry?
No, nothing. Just in Germany, just local meetings.
Not
And
in Europe.
Only in my state. I could travel to Europe if the country is not on the red list from the Robert Koch Institute. If it's on the red list and I come back, I have to go for 2 weeks in quarantine, and they will not pay it from me, they say. Uli, is the same in the Charité?
Yes, it's the same. Yeah. Yeah. They strictly observe everything. I had the chance to go to Greece for 2 weeks at least for summer vacation. But that was at the time when the infection rate in Greece was the lowest in Europe. Now they're catching up.
They're catching up, yeah.
Yeah. But not too bad. It's okay. They're still good.
Yeah.
We are unfortunately leading the pandemic situation right now. It's like 75,000 cases every day.
Wow.
How many cases?
75,000 a day.
Wow.
Last 5 days, that's what is happening consistently.
Yeah, that is a lot.
But surprisingly, the deaths are less. Even the serious patients coming to hospital and getting admitted in ICU is much less as compared to the past few months.
That's true.
But the number of cases are definitely much more still. You can't call it controlled or something.
No. In the US, they still have 1,000 deaths a day. So it's quite severe.
That's right. It's not a small number. I mean, it's a large country, but still not a happy situation.
No.
So now I'm waiting for Selma already with us. I cannot read her name. Maybe she has a different name on her
computer.
Are you here, Selma? Are you with us or not yet? You can write a chat and I find you better because on the list I cannot.
Yeah. Maybe there are showing 14 participants, so we should have everybody's name. No, unless she has Galaxy Alpha phone, she is not there.
She's still not there. There is one MI phone.
One MI phone.
We have 6 in the waiting room. I let them in.
I think now there will be a lot of people coming in quickly. Henry, do we have 2-3 minutes to talk? Do you think we should have turned this interim meeting into a web meeting? Anil Nanda is doing a meeting in a couple of weeks like that, 2 full days of meeting.
Yeah, I don't know. I think I would be better to make a face-to-face meeting next year, I guess.
Yeah, I think it's very exhausting. I don't think people will stay for a whole day meeting.
No, I don't think so. And we have covered the topics with the webinars. So I don't.
Yeah,
we discussed it. We discussed it in the board, and everybody said no virtual meeting, please. I don't know, but no, I think when we make the webinars, that's okay. We hope for the best that we can make a meeting later on.
Yeah.
So next year we should have the annual meeting in Singapore, hopefully, and then we should give the interim meeting in 2020 to Zurich. That was the plan.
Yeah. That's fair enough. I think our Hyderabad meeting may happen in next April, may not happen. We don't know yet.
Yeah.
Have you decided, Suresh?
Not yet, because it's really the situation is still not clear. What is going to happen in March, April? So far, we are hoping that by April things will be all right, and we should be able to organize the meeting, but it looks very, very, very difficult to
But
say.
if that happens, even then it is okay. The 22 meeting is in Delhi, so Delhi is a nice place.
Yeah, Delhi is also a nice place.
So Zulma is with us now. She is here.
Okay.
Hello, welcome.
Yes, yes, she's there.
I have to unmute you. I have to find you first here. So now it should be okay.
Okay, now I am.
Yes. Okay,
Good morning.
welcome.
Hey, good morning, good afternoon, good night, good evening to everybody.
Yeah, very good. That looks good. That looks good.
Yeah,
Okay, good. Let me see.
quite well.
How is everybody doing?
Good.
Good.
How are you?
Very good. Thank you. Hi, Ulrich.
Hi.
Akihito is also there. Hey, welcome.
Oh, thank you.
Yeah,
Hi.
so you are unmuted as well. So
Oh,
that
there he
sounds
is.
good.
We couldn't see his name in the list. Okay, now he's there. Hello.
So we have still some minutes. The only thing I don't know, how can we present the questions later on?
Imad should know. Imad is not with us. Are you there, Imad?
Imad wrote me a message.
Mhm.
So he has a link. He sent a link, but all participants should have this link as well. I don't know how do they do that.
After all these webinars, we don't know still all the little tricks.
Yeah.
But I mean, the multiple choice questions are for experts, I think.
Maybe, Henry, we can leave the questions for the end.
Mhm.
Yeah.
Yeah, of course.
By that time, hopefully, something, Imad will find out a solution.
Or I can see you.
Henry, we can send a message to Salman and see if he can help us on this.
Yeah, I sent already.
Okay, fine. So I guess we can start and wait for his message to come.
Yeah.
Yeah, it's 2 o'clock, huh?
8 a.m.
One moment, I have to let them in. All right. So it's 2 o'clock. I think we should start. Today we have it a little bit more difficult because our regular host is busy with a spine meeting, but I welcome everybody for our 10th webinar. And we have 3 speakers today, and we start with Uli Tomale. I think everybody's knowing him. He's a major pediatric neurosurgeon in Germany. He is one of the few independent departments of pediatric neurosurgery. He's working at the Charité, and he has a huge experience with a lot of endoscopic techniques. And he is especially known because of the lavage for intraventricular hemorrhage. And he initiated a very nice study, which is still going on. So Uli, we are looking forward to your presentation. Please share your screen.
Thank you very much. Oh, you have to activate me to share my screen.
Mhm.
It says the host needs to activate my screen or needs to give me the freedom. Du musst mir die Freigabe geben.
One moment. But I have here the messages. What? How? So one moment. Now?
I try again. No. Oh, yeah. No.
This is mine.
Just it's nice. Nice dog.
But one moment, I have Uli. He is Uli mehr. Aha, more. Video giver, host, co-host. Maybe I give you the co-host position.
Oh.
And
Then
now,
he will be able to, yeah.
now you
Yes.
should be
Now.
able to do it. Yeah.
Now it's good. Here we are.
Alhamdulillah.
Wonderful. So thank you very much for your kind introduction. And thank you also for the very nice opportunity to deliver my topic about neuroendoscopic lavage. And I just want to emphasize at the beginning that this is the 10th IFNE WFNS Neuroendoscopic Weekend update. So it's a kind of anniversary. Happy birthday to everybody. And the other thing is that we are actually doing since 10 years the neuroendoscopic lavage. So there's a kind of coincidence. So I'm very happy to give you the speech. First of all, everybody knows that prematurity is mostly the cause of intraventricular hemorrhage in neonates, and it's due to the fact that the germinal matrix is very weak and fragile, and we have thereby, by the bleeding itself, the primary damage caused to the parenchyma, and then the secondary damages relies on development of hydrocephalus, on inflammatory responses, which are actually due to the fact that the bleeding components are dissolved in the parenchyma. And then last but not least, our own complication, which we cause as neurosurgeons, as well as the comorbidities which are brought by the patients. These might lead to a neurodevelopmental delay, and grade 1 and grade 2 will already cause some delay of development, and it is much more severe in grade 3 and grade 4 hemorrhages. The comorbidities are quite severe, like enterocolitis, pulmonary complication, hematologic complications, and these have to be kept in mind that this will cause the outcome of the patients as well. If we talk about hydrocephalus and shunt rate in those patients, it's very vague what kind of figures are normally mentioned in the literature. And taken this very nice publication from 2016, where 150,000 patients were included, you can actually see that 9.3% of all IVH patients developed hydrocephalus, while 38.3% of IVH with ventricular dilatation received a shunt. So there's a combination of ventricular dilatation and shunting. And then 81.7% of the patients which were touched by a neurosurgeon for temporizing measures received a shunt lately. So looking at only IVH or only in ventricular dilatation, or if the neurosurgeon has already done some treatment, the shunt rate will differ significantly. The other thing is that if we look at the guidelines from 2014, they will not tell us very much about the topic how to deal with those complicated patients. So they say clinical judgment is required, which is a very wise recommendation. And they also say that ventricular subgaleal shunts reduce the need of daily CSF aspiration compared to reservoirs. And they say that reservoirs reduce the morbidity and mortality compared to external ventricular drainages. This is due to the published literature. There's another option, which is still unfortunately often used. It's the direct puncture through the fontanelle, as well as the lumbar puncture made by the neonates, and medical treatment. But all of those does not really have a real good effect. And especially ventricular puncture through the fontanelle causes more infection and more complication. That's why it's obsolete in Germany. Looking at the major three different options, we have the reservoir, subgaleal shunt, and external drain. The meta-analysis from Bativala says that the infection rate is similar in the reservoir and the subgaleal shunts, but astonishingly lower in the EVDs, that the arrested hydrocephalus rate is the best actually in external ventricular drainage, maybe due to the fact that you get all the blood polluted CSF out of the head. And however, the operative revision rate is quite high in the external ventricular drainage, which is somehow linked to morbidity. And this is significantly lower in reservoirs and subgaleal shunts. However, does anybody do the same? Do we have any guidelines, despite the fact that the 2014 guidelines does not tell us very much? A lot of surveys have been done. And here you can see that in the surveys that the different kind of treatment options, lumbar puncture, direct taps, reservoirs, subgaleal shunts, EVDs, and others are still all over the place. And everybody in every country and in every department does treat those patients differently. There are two prospective randomized trials in the literature about the topic. One is from the Netherlands, and it basically compares early intervention with late intervention, putting reservoirs and doing just taps to the reservoirs. But you have to acknowledge that both of these, compared to US American literature as well as to German literature, are doing actually early interventions in both groups. And the results they have is a very low shunt rate. And it was already debated by several other colleagues that maybe they have already treated a lot of patients which would never become in the situation to develop a real hydrocephalus. And they had a mortality rate of 11 versus 13%, very similar. So we don't know if we really compare or can take those data to the routine we use in other countries. The second prospective randomized trial is the very well-known DRIFT study. It was done by the Bristol group together with Belgian and Polish colleagues. And they put external ventricular drains in the frontal horn on one side and the occipital horn on the other side. They used continuous irrigation over about 3 days, which was ICP monitored, and also used hemolytic agents in order to dissolve the blood clots. They unfortunately saw a higher rate of secondary IVH. That's why they had to stop the study. However, they published in the patients which were included in the study so far, which were about 30 in both groups, the 2 years outcome, and they could see actually, despite the fact of the early complication of rebleeding, they could see that the severe disability rate was significantly enhanced compared to the patients who were treated conventionally without the irrigation of the external ventricular drainages. So that was an interesting technique. However, how to get a better control results, and that's why endoscopy comes in. And we have already published our endoscopic experience in preterm babies or neonates in 2013, and just showed what kind of different indications we have, and basically said that actually preterm endoscopy is feasible and is not as unsecure as somebody might think of. And the Great Ormond Street group just published in 2017 an age-dependent experience. And if you look at the group 1, these are all the neonates. They actually showed that they had on one side higher rates of shunting if they have done any kind of endoscopic intervention, but they had lower amount of complications actually compared to other age groups, which is quite astonishing. And they actually did also 3 patients who had an intracranial washout, so neuroendoscopic lavage. The technique of neuroendoscopic lavage was actually introduced by Sergio Cavalheiro from Brazil. And he published his only experience in an abstract from the Liverpool ISBN meeting in 2007. And there were 13 patients included. The technique was called brainwash in neonatal IVH. He used a 6mm endoscope, ringer solution at 36 degrees of Celsius, And 6 patients remained shunt-free, 7 patients were shunted, which is a shunt rate of 55%. And only 1 patient had an isolated fourth ventricle, which was both less compared to the patients who were treated conventionally. I discussed with him about the technique quite intensely. And in 2010, we were able to take his technique to our department and use it actually as a routine technique. Why do we do it? Because we think that it's a controlled environment in the operation room, that we can better control infection and volume balance compared to the drift approach. It's one intervention in most of the patients. However, you can do a second one if it's necessary. And we actually only access, compared to Sergio, the supratentorial ventricular parts, meaning the lateral ventricles on both sides, as well as the third ventricle. This is how it looks like at the very beginning. So it's just foggy appearance. Then you have to be very still, start your irrigation and get the CSF clear. Then you approach the clots, and the clots can be aspirated actively. Then you do a septostomy and do the same on the other side. What we do for indication, it's actually at the beginning is always intraventricular hemorrhage, which does not tell us that we have to intervene, because we always wait and watch if symptomatic hydrocephalus occurs. And if this occurs and is continuing, then we do neuroendoscopic lavage and we place a reservoir at the end of the surgery. If the hydrocephalus reoccurs after the intervention, which is mostly not directly, but maybe 2 weeks after, if at all, then we do a reservoir puncture of 10 mils per kilogram body weight. And then we wait until the body weight is about 2 kilograms. The protein level is supposed to be down of 2 grams per liter, and we should have a normal cell count. And then we decide about a ventricular peritoneal shunt at the end. So this is the protocol. The indications are generally, of course, intraventricular hemorrhage, elevated head circumference showing a progressive hydrocephalus. And the elevation of head circumference is, of course, not continuous, but it should be crossing the percentiles. And it's about 2 millimeters, more than 2 millimeters per day over 1 week. Clinical signs of bulging fontanelle, vomiting, bradyarc may be there, but maybe also linked to other comorbidities, but bulging fontanelle is a precondition. Ventricular dilatation in ultrasound, of course, is very important, measured in the ultrasound indices, and they should be much above the 97th percentile. And you can also measure the Doppler flow with a resistance index in order to see if the perfusion is low, and this was also like rush us a little bit more towards intervention. Here you can see from our first publication, the ultrasound indices measured as shown here, and they have all been way above the 97th percentile. So we can really say that we are treating hydrocephalus, not bleeding alone. This is one example where it shows the time course that was actually this year at the 20th of July, where we had an MRI in a preterm and not in a term baby, actually, not a preterm. And then over the time, we just observed, and we could see that the ventricles keep to be stable over time. The Doppler is okay. The resistance index is something about 0.6 maybe. And then after exactly 10 days, the ultrasound looks like this. Now the ventricles have become larger. The patient became symptomatic with vomiting and irritability, and then we indicated for neuroendoscopic lavage. This is how it looks like during the surgery. You can see this foggy-like appearance of the CSF, which is not so severe in this case. You can see the blood clots, and they can be approached with the outflow channel of the endoscope and be aspirated, which I show you later on. If you start aspirate them, then the CSF becomes even more foggier. And then you have to wait and wait. I think everything becomes clear again. Here it becomes clear. You can look in the posterior horn. Then we have cleaned up one side of the ventricle, and then we are doing the septostomy, which is now performed right here. And if you enter in the contralateral ventricle, and you go to the posterior horn, you will end up having more blood coming up. And then it becomes foggy again, and you clear all this blood out by irrigation until it will become clean as well. So this is normally the procedure, how it works. For intraoperative positioning, we use a vacuum mattress in order to fix the head. We place a more lateralized burr hole because we would like to do a septostomy as well, which is always in front of the fontanelle, so not through the fontanelle. Then we do an endoscope, an ultrasound guided puncture with the endoscope through the cortex in the lateral ventricle. We use either a 0 degrees MINOP or a LOTA without the outer sheet. And then we finally start the irrigation through one tube and the outflow through the other tube. And then we can balance the ICP during the intervention. A warmed lactate-free Ringer solution is used. Continuous irrigation and passive outflow is controlled by the second surgeon, who is right next to the first surgeon. What kind of endoscopes we are using? I said MINOP and LOTA. Why? Because we need a certain amount of irrigation and outflow channels, which are here on the side. This is the optic. This is the working channel right here. Here's the optic. And this is very important to have enough diameter in order to get a good balance of flow. And this is actually the same in the MINOP as it is in the LOTA. The LOTA we don't use with a sheet because the sheet is too big. And if you take away the sheet, the diameter is 6.1. And here in the MINOP, it's 6 millimeters. So this is a decent size. Maybe it seems to be quite big, but it's feasible not to leave any kind of big damages of the parenchyma behind. Please don't use the little LOTA because the little LOTA has too small irrigation channels. The volume exchange is basically not enough. What about the setup in the OR? It looks like this. And if we look at the details, of course, we have our endoscopic screen right here. We have the ultrasound right next to us where we do our ultrasound guided puncture. Then we have the endoscope here and here, and we have the two tubes. And one tube is going to the second surgeon, and the other tube is going to the bag of the Ringer solution, which is going all the way down by gravity inside the endoscope and then inside the ventricle. Finally, the syringe is guided by the second surgeon, and the second surgeon is putting the syringe on and off in order, if you approach the clot, you can basically then activate the more aspiration and then get the clots through the outflow channel in the tubing and then outside. Here you have a quick view, ultrasound, the ultrasound guided puncture in the ventricle right here. Then you can see at the very beginning, here is a very blood polluted CSF coming outside the ventricle, which is aspirated. And the second tube, here's the screen, is coming from here, right there. There's the irrigation coming all the way down by gravity in this clear tubing from the other side. And the outflow channel is going to a bag, which is just in front of the surgeon himself. We can also start the other video. You can see that if you approach the ventricle, you have to move your endoscope around. And this is the delicate thing because this head is very small, as you can imagine. And this is something which you need to experience not to make any damage to the very fragile brain. But you can basically enter within all the parts of the posterior horn in order then finally to aspirate all the blood clots as well as the third ventricle. The amount of volume we use are about 3,000 mils. The OR time was here 70 in mean and 36 up to 108 minutes. If you look at the endoscope screen, you always have to imagine you are looking only from one part of the endoscope. The other parts of the endoscope are actually just above you with a working channel and the irrigation channel and the outflow channel, as you can see here. So the clear water is coming here on this side, and the outflow is coming on the other side. This is something you have to keep in mind if you look at the screen of your endoscope's monitor, because this is how you approach your clots. This is the outflow channel. So in this time, it would be better to have your outflow channel here, which you can switch actually during the surgery. And then you can approach with the lateral view here towards the outflow channel. Then the second surgeon will aspirate gently and then will get parts of the endoscope. The other thing is that you can switch it back. If you have, for example, the choroid plexus, and sometimes the choroid plexus will get inside the outflow channel, because there's always some kind of outflow and suction activity, and you don't want to mess with the choroid plexus too much, because otherwise it's getting more bloody. What about early or late neuroendoscopic lavage? Here you can see the difference. If you do an earlier neuroendoscopic lavage, the ependoma looks more clear, which looks maybe more rational to do it as early as possible, because then you will leave more or less normal circumstances behind. If you look at the late neuroendoscopic lavage, you have an ependoma with full of hemosiderin all the way covered on the ependymal sides. And of course, you cannot get those particles. You only get the blood clots, which are solid, which are easy to aspirate. Everything which is more sticky to any kind of tissue, we just leave behind. We will not force anything to get out. But this is maybe the circumstances which you can imagine will make a difference in terms of the necessity of shunt. After finishing the neuroendoscopic lavage, we put a ventricular catheter attached to a reservoir and sealed around with gel foam. And then we put it all the way down to the corticotomy, put the other gel foam here at the bone level, and then we do a subgaleal and periosteal suture first, then a subcutaneous suture, and then the cutaneous running suture, as you can see here. And by pushing by the sutures the reservoir down on the burr hole, the CSF leak risk is not as high. This was one of our first cases in 2010, in September actually. In this case, was actually developing hydrocephalus in the late run. Then we indicated neuroendoscopic lavage. We cleared the ventricles on both sides, left a reservoir behind. This patient never needed a shunt, and we put out the reservoir like 1.5 years later, and then was not needing any further follow-up from our side. The other situation is, of course, very premature baby, severe hydrocephalus, was referred from another hospital to our unit. We did neuroendoscopic lavage, we put a reservoir, we needed to put a shunt later on. And then the patient needed another valve exchange because of occlusion of the valve. And then no further revision of the shunt were necessary in the intermediate run for this patient. So in general, our first experience was that we could see that not all patients needed a shunt. Our shunt rate was 60%, a little bit lower than 60%, 58% actually. And we could also see that our infection rate was lower in neuroendoscopic lavage compared to our historical conventional treatment group. And we did not have any multiloculated hydrocephalus. So these were the big differences of advantages. These were only experiences from 19 patients, so not so much. But then we published in World Neurosurgery a combined series with Leipzig, a smaller unit south of Berlin. And there were 56 patients in total. And those 56 patients had at the end a shunt rate of 57.4%, so also very similar. And our operation time was 73 in mean and 80% in the non-shunted. The non-shunted patients were a little bit with higher body weight at birth. But they were a little bit younger during the neuroendoscopic lavage, indicating that maybe an earlier neuroendoscopic lavage might have a benefit. However, that was not significant different. The other thing is what kind of amount we get from the neuroendoscopic lavage of bleeding outside. And you can see here all the blood inside the ventricles, and the postoperative image still shows some blood here in the temporal horn, which is more or less a typical situation. If this is attached to the choroid plexus, you cannot get around. If it's loose, you can actually irrigate it out by just putting the irrigation in this region. But if it's too attached, we just leave it behind. So we measured the amount of blood which we got out, and we saw after surgery in the lateral ventricles, 60% of the ventricles has less amount of 10% of blood. And on the other side, that after surgery, ventricles with more than 30% of blood preoperatively were significantly higher, and at the end, after surgery, we only account for less than 10% of all ventricles. So the amount of blood you can get out is really significantly high, but you will not get everything out. What about complications? We had 15 complications in 56 patients. There was rebleeding in 5 patients. However, 3 were not really significant and nothing was done to those. 2 were significant and we needed to do a neuroendoscopic lavage. Infection was 3.5 in terms of finding CSF germs, but 6 received antibiotic therapy due to any infectious reason. CSF collection of fistula with no intervention in 2, and 3 received a suture. None of them received a second surgery. Mortality was 5.4%, and 1 patient actually had a mortality event after neuroendoscopic lavage, after the rebleeding. That was in the center during the learning curve, which shows you that this is not an easy surgery. Maybe it's an easy surgery if you have established everything and it looks quite routine. If you don't, it's not too sophisticated, but the whole procedure with anesthesia, with neonatology, with the fragile babies, it is some kind of dangerous as well. However, if we look and compare again to the results from Bativala, our publication showed that the infection rate was lower, the arrested hydrocephalus rate was higher, that the mortality was lower, and the operative revision was lower. But that was only in 2 centers, and this is hard to do, compare, of course. There are then other surgeries to be done as well, and we looked here at all different kinds of other surgeries. If you have put a shunt, there might be shunt revisions. If you put a reservoir, the reservoir needs to be taken out if it's not necessary anymore. So if we look at the total amount of surgeries which need to be done to the patients compared to the ones which we had in our conventional group, it was still significantly lower. Also, our shunt survival curve in the post-hemorrhagic hydrocephalus after neuroendoscopic lavage looked quite reasonable to us and did not cover any more second surgeries, not too much second surgeries below the curve as well. What about other centers? Other centers have started neuroendoscopic lavage, like the Turkish group. There were, I think, 3 different hospitals showing that the endoscopic ventricular irrigation, how they called it, caused less infection, caused a lower shunt rate, and had lower amount of multiloculated hydrocephalus. So basically the same what we could saw in our study and our experience, and that was compared to conventional treatment and to ventricular subclavian shunts, which were in both parts with less favorable results. Another group is in Sevilla. They have done quite a lot of neuroendoscopic lavage as well. They are very similar in the technique which we are using. However, they're using a cannula in order to aspirate the blood clots, which can be of advantage because you can actually see the cannula. You put the tip of the cannula towards the clots and then you can aspirate. But this is a technical nuance. You can decide one or the other. Their infection rate was a bit higher than what we saw, and it correlated with the amount of lavage they have done to the patients. So they did up to 3 lavages, and with the 3 lavages, the infection rate was the highest. The other difference was the survival curve for the shunt. It was a bit lower to the one I showed you before from our series. What about outcome at 2 years? The only thing we can compare is the drift study. This is our outcome. This is the Bailey score, and this is the motor score of gross motor functional classification scale. Drift study compared to neuroendoscopic lavage in Bailey score is very similar. So we had something like 45% who are doing well, and we had something like 55% who are not doing so well after 2 years. So this is the drift treatment group, and this is the drift motor score. And here, neuroendoscopic lavage seems to be better because our severe disabled, motor disabled patients who were not able to walk alone had a higher rate compared to the neuroendoscopic lavage group. But of course, this is only literature comparison and very weak in the conclusion you can draw. But nevertheless, it's something we can say. Here we can say that anti-epileptic drugs, comorbidities, these are some kind of important factors. Also, cerebellar atrophy and isolated fourth ventricle are the factors who are dependent for outcome, as well as the gestational weeks. But this is only univariate logistic regression. In the multiple regression, you cannot find real significant predictors. However, this is the direction it will go. Again, in all those series, we did not have a multiloculated hydrocephalus anymore, only a few isolated fourth ventricle, which were in total 3 in the whole series. We did also volume measurements, and the volume measurements nicely correlated to the Bailey score as well as the motor score, but the motor score was even a little bit better. So we can do some volume measurements in the future as well. Why is this so important? Because the drift study showed that in the 10-year outcome after drift, they were actually keeping up the good outcomes for neural development, and they could show that the financial burden to the health system was much lower because they reduced the amount of severe disability. At the end of my talk, I will just announce our nice study, which we are doing together with the International Federation of Neuroendoscopy. It's the trophy registry. The aim is to define the safety and efficacy of different surgical treatment regimens, to define complication rate, shunt dependency, and neurological outcome of the different approaches to neonatal IVH. This is the steering committee. This is our website where everybody can register who is interested to participate, trophy-registry.org. And the types of intervention is not only neuroendoscopic lavage, it's also external ventricular drainage, reservoirs, and subgaleal shunts, so that we can later compare those over a long-term follow-up until 5 years of intervention. Inclusion criteria is mainly preterm neonates with IVH and hydrocephalus. And this is the big community which have already grown. We have 61 centers registered, 22 centers who are active. We have 75 patients included to the study already. And Russia is the biggest country at the moment because they put a national emphasis on this topic, which I'm very grateful of. And I invite everybody to participate in the near future as well in order to get more information. This is again our collaboration and our group in Berlin, which I'm also very grateful about. And this is just to make our patients as good as possible. Thank you very much.
Thank you, Uli, for this nice presentation. It's really a very nice work, and it shows that I think the outcome can really improve by simple endoscopic procedure. That's very nice. So if somebody want to raise a question, you could raise a hand and I can look. We had in the chat a few questions. One moment. The first question is, did you get any significant bleeding in any case? And if yes, what did you do?
Yes, we had one case in our cohort with a significant bleeding. And this was actually a bleeding which was as severe that the total amount of blood was the same like as before surgery. What did we do? We did not do anything at the beginning. We just observed the patient. The patient kept to be intubated. We were very reluctant to do anything too severe to the patient. And we discussed with the neonatologist first to stabilize the patient and then decide how everything develops. This patient was I think below 800 grams, so very small one. It has severe comorbidities. And then for the long run, we decided not to do any patient again at 800 and below. However, after 14 days, this patient became stable enough. So we did another neuroendoscopic lavage, and then we stabilized the situation, later received a shunt, and then everything was okay. So we kept to be on the protocol with this patient. Later, after 2 years, we still crossed the line of 800 grams again, because nothing happened after this case, and I've never seen such a rebleeding again. Only very minor bleedings, which we were not so astonished about. So this is how we dealt with this case.
Okay, another question from Arthur is, do you do an endoscopic third ventriculostomy in your cases?
No, normally not, because we think the blood is the major point to get out. I have done a very few amount of ETVs in those cases, only if the blood was already mostly resolved. And to have at least a little effect, I did an ETV. But if there's a lot of blood inside, I don't see the reason to do an ETV as well. And especially, we don't want to put too much risk on the small patients, because if we do some harm, then we could stop the program. So we avoided to do ETVs actually. But I know that Sergio Caballero, for example, is doing most of the cases, he's doing ETVs.
Yeah, we have done a few cases with ETV, but if you look under the floor, all subarachnoid space is completely filled with blood and adhesions. I think it's not working well, and it's not worth to take the risk, at least in the cases we had in the few.
Yeah.
So Kinishi gave a short suggestion, so I give him the voice. He's suggesting it, that simple robotic surgery will do it, so we don't need you anymore, Uli. Kinishi, can you explain what you mean?
Maybe I can comment on it. I think I will be retired if this is the case.
Yeah, I just looking at him. I cannot find, where is he?
There's Kinishi, I see it.
Kinishi, please. Yeah. Do you have a small Japanese robot who makes the job for us?
Still, I don't have it. Can you hear me?
Yes.
Yeah. I still not have it, but I think that this is the only simple technique to irrigate and remove the hematoma. And I think the aim, the main object of this operation is to exchange the CSF to the new artificial CSF. Then maybe that avoid their making the complex hydrocephalus. I think so. So it is very simple technique. So it will be changed to the robotic techniques. That is my opinion.
Yeah.
How do you think about it?
I think this is due to the fact that you are a visionary man. Mm-hmm. I think in the future it might be right, but I think there's a lot of work to do. I can promise you we get a robot in next week, actually. But I think a few years will go that we can actually introduce an endoscope in the robot, because it's not applicable at the moment. But I think to combine robotic surgery with endoscopic surgery will be quite interesting for the future. Yeah. If you should start with the neonates, I doubt it, because it's a too fragile situation. I think you start with very more standardized ETVs, for example. Mm-hmm. And the other topic you just said with artificial CSF, I would agree to use artificial CSF, but in Germany we are not able to buy artificial CSF in this amount, how we need it for neuroendoscopy. So we have to use lactate-free ringer solution.
I personally are also very reluctant with robotic surgery in the brain. Even the orthopedic surgeon gave up with the hip because it was not so successful. But let's see in the future. There's a question from Sandy. Sandy asked whether you have seen trapped forced ventricle. You mentioned it. You had a few cases, right?
Yeah, we have seen in 45 of our series, which we evaluated like 2 years after, we only saw 3 cases with isolated fourth ventricle. None of them had isolated lateral ventricles. None of them had multiloculated hydrocephalus anymore. And that was not the case in the previous series before we started neuroendoscopic lavage. So I think neuroendoscopic lavage is the perfect technique to avoid multiloculated hydrocephalus.
Okay, and then one last question, because we have to continue, we run out of time. Adrian is asking, do you see any electrolyte imbalance after infusing 3,000 cc's of fluid into such a small brain?
Yeah, that's an absolute reasonable question. I haven't seen it, which is clinical relevant. We see some kind of shivering of the patients, only a few, maybe like, let's say 10 to 15% of patients have some kind of ongoing shivering of the muscles. This lasts maybe 1 or 2 days. I don't know if it's due to the fact that it's electrolyte balance, but it will stop after, as I said, 2 days, and then they can be extubated, let's say 3 or 4 days after intervention. So it was not an ongoing problem actually. And we looked at our anti-epileptic drug medication, and all of the patients had lower amount of anti-epileptic drug after surgery compared to before.
All right.
Well, let's just the last question. Last question, Ulrich. Can I?
Okay.
And
last question.
Okay.
Last question.
Yeah. You keep a drain in the ventricle system post-operatively. Is that right?
A reservoir.
How long? Yeah,
a
the
reservoir. Close.
How long do you keep it? Yeah. How long do you keep it, and how do you manage the hydrocephalus with this?
Suraj, it's just a reservoir. It's not an external drain.
Yes.
Yeah,
Just a reservoir. Just a reservoir.
So you don't
There's no
aspirate.
connection
You don't aspirate it regularly, correct? Is that right?
Yeah. We don't touch it at the beginning, and we wait until hydrocephalus dynamics reoccurs. If there's no hydrocephalus reoccurring, we never touch the reservoir anymore.
Okay.
And we leave it mostly at least half a year or even a little bit longer, but that depends on the parents. If the parents want to have it out, we put it out. If they want to keep it in, we just keep it in, because it doesn't do really harm, you know.
Okay, thanks.
Yeah, Uli, thank you so much for this very interesting presentation. I enjoyed very much. And I give the voice to Suresh, who can introduce the next 2 speakers.
Thank you. Thank you, Henry. Our next speaker is Dr. Julma Tovar Spinoza. I think a lot of us know very well Julma, her work and her presentations in various international meetings. She is an associate professor of neurosurgery, neurology, and pediatrics, and actually the director of pediatric neurosurgery at the SUNY Upstate Medical University at Syracuse, New York. It is my great pleasure to invite Julma to present her presentation today. Julma. You can unmute yourself and share
Henry,
the screen.
I think you have to unmute. I don't know how to unmute.
Okay, now I'm unmute.
Okay.
Great.
Thank you, Ulrich. Let me share my screen for a second. Oh boy. I'm trying to share my screen. Okay. Sorry, guys. I'm not sure where my sharing screen went.
I think.
Ulrich, you gave me voice, but now I cannot share my screen. Let me see.
Henry has to do it.
We have to, yeah. We have to include as a host.
Oh, here we are. Found it. Okay, let me just go here. All right. So talking after Ulrich about neuroendoscopy lavage, it's a little bit an undertaking. But I will try just to go to the basics of what we do, right? And obviously, when we talk about ventriculitis, it's something that every single one of us as neurosurgeons has been confronted, and we do know how challenging it is to treat these patients and why we do it. It's obviously, as we already just said, these patients develop severe complications like brain abscess, adhesions, septations into the ventricles that we try to avoid. But we forget also that what we try to avoid in these patients is basically the long-term effects of having these difficult conditions, mostly, the morbidity. And as reported, these patients can have only not significant mortality that has been reported to 19% for some gram negatives. Even in preterm babies, you can report even a 40% for E. coli ventriculitis, but a significant morbidity for persistent vegetative state to a severe to moderate disability. And this is a courtesy of Dr. Felipe Chabelas from Mexico. And these are the things that we try to avoid. And this is passed into the ventricle, into the aqueduct, sorry. The early diagnosis is very important, and we just go back to the basics. How we do this diagnosis, obviously we will want to gather some laboratory data. We take in samples for cultures and increase cell counts and the protein levels. That the protein levels in the long term are very important for what is going to be the long-term treatment. We have a clinical information, but nowadays in the centers or in the countries where we can have CAT scan, you can see the CAT scan with contrast, but where we are very fortunate that we can evaluate the MRI features. And the MRI features that we see are the periventricular debris and the periventricular hyper intensities, especially in the diffusion weight images, which are the ones that are the most sensitive modality for detecting the ventriculitis. And as Ulrich just mentioned, the one thing that we want to avoid is the horrible hydrocephalus that can develop. And these hydrocephalus are, despite this develops in many countries or many places, it doesn't matter which part of the world you are, and you're given the right antibiotics to these kids, they develop. And as Ulrich and his group published, in pediatric populations, what is important to avoid is not only for the hydrocephalus itself, but also for the long-term cognitive and developmental damage that this can cause to these patients. The hydrocephalus, and we all know this type of images that we try to avoid, is multifactorial because we have impaired resorption of the interventricular proteins, bacterial contamination, and pus-induced inflammation. And obviously that creates problems on the resorption of the CSF and obstructions on the pathway. And it remains a challenge because we have this intraventricular debris and also the potential for secondary infection. And this is from a group from Japan. And you can see how just leaving these remains and in the ventricles, since the ventricles are not totally clean, can indicate a significant chance for reinfection. So therefore, the early goal of treatment will be the early and consequent antibacterial therapy and the restoration of the CSF normality. But for this CSF normality, we all know, but for getting the normal levels of proteins is going to take long term. We try to avoid this, which is, looks like a classical old picture, but we all have a patient or two that look exactly like that on the x-rays. And we all use different techniques as Ulrich, you just mentioned. We use the conventional treatment of the antibiotics that are specific for that specific type of bacteria. Some of us use ventricular EVDs, or other ones use reservoir placement or ventricular peritoneal shunt. And every single one does according to the convenience, or also subgaleal shunts. And the secondary CSF infection may be induced for post-surgical complications, but it's not related only to the hydrocephalus. So Ulrich just explained about the intrathecal therapy. Some initial studies spoke about active irrigation of the ventricles, that's trying to give a solution to this program by using a closed system of external drainage where you will watch the ventricles and apply intraventricular antibiotics. However, we all know that antibiotics are not really made for being intrathecal, and actually in so many cases, they can be just decremental to the quality of the absorption of the ventricles, and it can lead you eventually also to hydrocephalus because you are just ruining the parenchyma of the ventricles, and these patients cannot absorb CSF. But also, if you keep these patients with a long-term external drainage of any kind, you can actually increase the risk of infection by aggravating the bacterial ventriculitis by retrograde infection. The intrathecal therapy has been debated. Usually, we all have a patient with a staph or with Enterobacter or with Acinetobacter that have this kind of infections that are super resistant to antibiotic treatment. But there are just very few reviews or reports that treating these patients with hydrocephalus by only intrathecal therapy is actually effective by itself. Therefore, we come our friend Ulrich, as he explained the same concept and the same principles for the IVH. This group, the group of Berlin, applied the same principles for treating CSF infections. And on this paper that they published in 2018, they compared the patients with a control study and the patients where they did an early neuroscopic lavage. And on these 23 patients in the long term, they noted that the protein and the cell count on the CSF was significantly reduced from the control group, but also the rate of BP shunt on this control on the group that has the neuroendoscopic lavage was smaller even in the 2 years after the discharge, after the treatment of these patients, and the rate of the shunt revisions was also significantly reduced. And this is a courtesy of Dr. Tomali too, and this is one of the patients that they see that they treated, 24-week-old baby. Actually, Uri, this is one of your little ones with 500 grams, which kudos to you. And this is the appearance when you go inside the ventricle. Uri already described this wonderful system. I find this very creative, and doing this on a lavage where you use the Ranger lactate that is in a normal temperature, it goes through one channel of the endoscope, and actually the dirty CSF goes to a bag. It's a closed system in the OR, as you described it just in your previous talk, and until the CSF comes clear. And this is what it looks in the long term. This is also just to mention that as you just discussed with the IVH, most papers and case reports are telling us that the earliest that we do this neuroendoscopic lavage is probably the better, because it's going to reduce the amount of inflammation. In most of the cases, you can have trapped ventricles from one side, and therefore it's indicated to perform a septostomy in these patients, also to increase the quality of your lavage. I will agree that you try to do this lavage only in the supraventricular, in the supratentorial ventricles, because these patients that are too little, this is a very invasive procedure, but also in adult patients, you try to avoid the complications. So this is the group of Japan. They propose a septostomy combined with the intraventricular irrigation for these patients, and then achieve a significant cure from 6 to 7 weeks after treatment. The group for Mexico, and this is from Dr. Chavelas that he presented on the last IFNE in Orlando. They have treated 24 patients with endoscopic lavage. They do it a little bit different. They actually irrigate. Let me just move this away. They actually irrigate with Ranger, but also they use amikacin on their irrigations. Obviously, it's on room. It's also on body temperature, And this is where you see they get on trying to lavage the pus from the ventricles, but also, if not possible, they also grab it out. And once they finish this lavage, 3 days later, they take samples from a lumbar puncture or transfontanel sampling to see what is the quality of the cells and the proteins and the cultures. And if that looks infected, they will repeat the lavage. But the difference with them is that they actually don't leave any external ventricular drainage. They actually don't leave any drain afterwards. And here you can see the pulse on the ventricle and how that looks very cloudy, and how sometimes you just need to grab the pus from the ventricle to clear the pathways. And this is from the group in Indonesia about the importance of, they reported a couple of case reports about the importance of clearing the ventricles. And this is the initial view. And here you see once they clean up the walls, and how after you clean up the walls, actually you can see the amount of inflammation of those ventricular walls, and how important this is to eliminate the risk for recurrent shunt infections. These patients require long time treatment, and just for making eligible for shunting. And then infectious hydrocephalus, we know with shunt, they don't clean this, they are probably 100% chance of reinfection, while other groups, including the group of Tamale, have reported a much lower rate of reinfection after shunt when they are after the neuroendoscopic aspiration. And the group of Kumar also reported the patients with severe ventriculitis and with gram-negative bacteria. And this is a group that is very, very difficult to treat. As we all know, they just only reported 7 cases of patients treated with Acinetobacter. And they did an early endoscopic lavage and IT therapy. And the treatment actually lasts up to 8 weeks. They had 1 mortality despite of doing this, which is just tell us the severity of this infection. And they recommended to do the endoscopic lavage when the ventriculitis is persistent between 7 to 10 days after IV and intrathecal antibiotics, which probably at this point we'll agree that we will try to do that on a most early fashion just to try to improve or to avoid the inflammatory response of these ventricles. So in conclusion, the bacterial ventriculitis causes significant mortality and morbidity. I will believe that rapid drainage and irrigation of this pus and debris needs to be probably a little bit earlier than waiting 7 to 10 days, because then we're going to find ourselves with a severe inflammatory reaction, and that can lead to changes in our prognosis. Obviously, the early diagnosis is very important. And as we said, it's not only the clinical and lab data, but also the play for the MRI on doing this diagnosis. The most significant signs of ventriculitis are the intraventricular debris and pus, and the endoscopic aspiration lavage we know is effective, according to the few cases and the few literature reported. And after the initial treatment with pure antibiotics or intrathecal antibiotics has failed. And overall, when we do it well and we control these patients, decrease the number of overall the shunt, not only insertion, but also revisions, and is a safe and effective in the treatment for infectious hydrocephalus in little kids and children. And this is from this morning from my backyard, and that there is an airplane there, meaning that we are still hopeful that we are going to see each other in person very soon. Thank you.
Thank you so much. Suresh?
Yeah. Okay.
So,
I can't see anybody. I can see. Right. Can you, shall we take some questions, Henry?
Yeah, you could go, you are co-host, you can go to chat and read the question.
Yeah. Mm,
There are 2 questions.
There are, I don't see any question in the chat box.
Okay, I can.
You can see, please go ahead. Yeah.
There's one question. Is there any upper limit for the volume of fluid used for lavage? What is the outflow fluid? Does not become clear. What if the outflow fluid does not become completely clear?
So for the all the cases that are reported, most of the papers report up to 3,000 cc's. The outflow fluid there is reported to go to a closed system to obviously to avoid to contaminate not only the patient but also the OR.
Next question is, do you keep an EVD after lavage for ventriculitis cases? Or do you remove it? You don't place it?
I think in my case, I do that according to the age of the patient. If the patient is very little, I do the same like Ulrich does and just leave a reservoir. If the patient is an adult patient, we do leave an EVD in order to be able to take samples and we take repetitive samples until we get to know if the infection is actually under control, or and when we can, if the patient requires a shunt, when we can perform the shunt insertion.
Oli, any comments from your side?
Yeah, it's basically the same. I mean, the whole thing with ventriculitis, it's a devastating situation because if you don't do anything, you have to wait and wait and wait until the infection becomes resolved. And this to do with only systemic antibiotics is an almost never-ending story because reinfection risk is very high. So to get this out with the technique of endoscopy is a very effective one, which has shown now by many groups, not only in children, but also in adults. And we actually started with neuroendoscopic lavage in ventriculitis, not in hemorrhage. But then we focused our research more on hemorrhage. And I totally agree, and I would like to congratulate Sulma for the nice talk, that EVD is necessary if you have an ongoing infection and you would continue to get out the polluted CSF. Our upper volume limit is a little bit higher. We become nervous at maybe 5 liters, and then we think about the 6th one. Sometimes we just stop and then leave it for another intervention, for example. But the question is how stable the whole procedure went. If everything is okay, you might continue a little bit. So it depends on the whole situation and how old the patient is. If the patient is older, you can push it a little bit longer.
Yeah, that's great. And then that's when you have those big talks with your anesthesiologist on how the patient is doing. Because on little patients, it makes me really nervous to do more than that. In adult patients, you feel much more confident that you can just keep going. And you know, sometimes when the patient is not doing that well, you can always say that you can always come back another day.
Yeah.
Okay, there's one question from Arthur. Please, Arthur, ask your question.
Oh, yes. Suman, congratulations about very nice talk. I want to do the same question that I did to Ulrich concerning the possibility that our patient develop closing of aqueduct. Do you do the ETV after the lavage? And another question is, we observe that by the ventriculate, the epididyme is very friable. Do you have bleeding very often, and how do you do?
But unfortunately, I don't have these patients that frequently. However, I will agree with Ulrich said, especially for patients, same principle that with IVH. I think if you have a case where you already have significant hydrocephalus and you can actually see some normal anatomy, if the patient it's an older child or an adult, probably you may want to try to do an EVD to try to avoid your shunting in the future. However, again, I think it's a very individual decision. Depends on what is the degree of infection, and that will be the advantage of doing these endoscopic lavages early, because your anatomy is still somehow preserved and you can take the pus out and still don't have such an inflammation of the ependyma. And still you don't have such a significant arachnoiditis in front of the pons for your ETV, therefore have a little bit of more rate of success than when you already have an advanced ventriculitis with septations, with I think your rate of success will be much limited.
Maybe I can comment on this, that ETV might cause harm in those patients as well. If you have a pure ventriculitis and the infection is only in the ventricles, better leave the floor of the third ventricle closed, because you don't spread the infection further to other compartments as well, which can be much more complicated. And it's an ongoing inflammation. It's a dynamic situation. If you do an ETV, it will do no benefit to you. The only benefit it can bring if you have poos in front of the pons and you want to suck this out as well. But I rather think it's a little bit dangerous as well. So we try to avoid it, especially in ventriculitis patients. It makes
I will agree with
that. That is a valid argument, I think. So one last question from Chandra.
Well, I just wanted to ask the same question, but you know, Shizuo Oi has been telling us in India that we also do not have artificial CSF, and he feels that the Ringer's lactate which we use, if we add some bicarbonate to that, we get somewhere very close to it. So we are using that regularly. Any experience with that? And in the infected cases, do you use intraventricular antibiotic as well while doing this wash towards the end or at any time?
No, we don't have also artificial CSF. We use Ringer for lavages, and I don't use intrathecal antibiotics during these cases.
Yeah, the same for us. It's actually not licensed for Germany to use intrathecal antibiotics. So it's only an individual treatment approach, which you cannot do on a regular basis. For the lactate-free Ringer solution, you will have enough balance of the pH level. So it will be, if you get this in India, it's also completely fine. You don't need to add something else, in my opinion.
I think what is very important to remind to the people that is just starting to do the things is just pretty aware that no matter what you use, it's about the electrolyte disbalance that they come up from these lavages to these patients, especially the little ones, but that can also happen on the adult patients. And be aware that these patients can develop severe hyponatremia post-procedure, and you really need to follow and track on this.
Is
Maybe
there any kind of flow rate you decide? Or is there a particular flow rate which you use?
No, it's defined by the diameter of your tubing and the pressure you apply on your bag. If you just use gravity, it will be decided by gravity. We just want to have just a flow in the reservoir just below the bag. So not more, not less.
And same with the others. I use also gravity. And just if I need to aspirate something that is attached to the ventricles, I use a syringe to aspirate that. Some groups have reported the use of some type of little cannulas inside the endoscope to try to remove the debris. But I usually just hold only gravity, especially the patient is tiny.
Just one last comment to the electrolyte disbalance. I think this is not as important as we think if you use lactate-free Ringer solution. The much more difficult issue is the temperature of the solution. And if you use a lot of volume, you need to make the nurses bring the bags right from the heating box or heating chamber into the operation room. This is a tiny little thing of infrastructure and organization, but it may be quite an issue during surgery, you know. So we always keep our lactate-free ringer in a heating box, and we take it just from there to the OR to use it in the patient.
We do the same, and you just wanted to make sure that you have enough bags there too.
Yeah.
All right. So thank you, everybody. So we should continue. Suresh, please introduce our last speaker.
Sure. Right. Our next speaker is Dr. Kazuhito Takeuchi. Dr. Takeuchi is a clinical associate professor in the Department of Neurosurgery at Nagoya University, Japan. He is going to talk about endoscopic surgery for intraparenchymal lesions. Dr. Takeuchi, you can please unmute yourself and share your screen.
Okay. Can you hear me?
Yes, thank you.
Okay.
Share your screen, please.
Thank you for inviting me to this conference. I'm Dr. Takeuchi from Nagoya University. Nagoya City is the central part of Japan here. This is my hospital. And sorry. Today's topic is endoscopic intraparenchymal surgery for intraparenchymal regions. Nowadays, endoscopy is widely used for the transsphenoidal surgery and ventricular surgeries. And in this intraparenchymal region surgery, we use a cylindrical shape tubular retractor to keep the surgical corridor, and the removal procedure is completed inside the cylinder. This surgical technique originated from the hematoma removal surgery, so I want to talk about the hematoma removal surgery first, then move to the tumor removal surgery. Various minimally invasive hematoma removal technique is now available. Some trials already finished and some trials are still ongoing. But this time I want to talk about the Japanese style hematoma removal surgery. This surgical technique was invented by Dr. Nishihara in 2000. But nowadays, this surgical technique is commonly used in Japan. This is our surgical technique. We use a 6 millimeter or 10 millimeter diameter translucent sheath. The sheath was held by assistant, and the main surgeon holds the endoscope and suction tube and insert them very coaxially to the cylinder like this. Various sheaths is now available, but we use this one, Neuropod and Neuropod Mini, 10 millimeter or 6 millimeter diameter sheath. This is our surgical technique. We made a single bar hole on the skull. This is skull and this is hematoma. For cylinder insertion, I use a navigation system or ultrasonography guidance and insert the cylinder to the hematoma like that. Sorry. And endoscope and suction tube inserted very coaxially like that. And evacuates the hematoma from top to bottom side. Generally, the hematoma protrudes into the cylinder because of the high intracranial pressure, like this. So, remove the hematoma inside the cylinder first, then remove the hematoma just in front of the cylinder, little bit like that. After that, tilt the cylinder to locate the brain edge here and remove the hematoma at this part, like that. And tilt the cylinder again to follow the normal brain edge and remove the hematoma at this part. After removal of the hematoma just in front of the cylinder at this level, insert the cylinder several millimeters and remove the hematoma again in the same fashion. insert the cylinder again and remove the hematoma, like that. If you find the bleeding artery, like that, place tip of the suction tube on the edge of the artery and place the monopolar coagulator on the top of the suction tube, opposite sides here, like that, and coagulate it. And if you encounter the hard clot, don't pull it. Bleeding vessels possibly exist behind it. If you pull it, severe hemorrhage can be occur. So don't pull it. But there are soft and mobile hematoma usually surround the hard clot. So evacuate the soft clot first, and you can get a much wider space here. So you can mobilize the hard clot and remove it. But the most important thing is thinking about the necessity of removal of the hard clot. The amount of the hard clot is usually very small. So, and the gross total removal is not the main purpose. In the MIST-3 study, less than 50 milliliter residual hematoma is acceptable. So you can leave it alone. After the removal of the hematoma, to confirm the complete hemostasis, fill the hematoma cavity with water. And after confirming the complete hemostasis, insert the third cell inside the cavity. Generally, the hematoma cavity shrinks after the hematoma removal, so no need to insert a large amount of sagittal. Small amount of sagittal is enough. This is a key point for safe surgery. Don't evacuate far away from the cylinder tip, like this. If you encounter the bleeding artery at this point, there is no enough space, so it's very difficult to handle the hemorrhage. And don't go deep before evacuating the hematoma around the cylinder tip, like this. There is no landmarks inside the hematoma cavity. You will lose the orientation. Please remove the hematoma like this fashion. It's much safer. And don't remove the hematoma strongly adhering to the surrounding brain, like this hematoma. This is a setting. Put the endoscope system in front of you. We insert the endoscope and suction tube very coaxially. Of course, the assistant holds a cylinder, but at this moment, we have to recording the surgical site, so no assistant here. Okay, in this patient, the patient had a abdominal hemorrhage. We made a single bore hole like that. We insert the test-up needle with navigation guidance and evacuate the hematoma a little bit. After that, insert the cylinder like that. Evacuate the hematoma inside the cyst and evacuate the hematoma just in front of the cylinder like this. We have to always see the normal brain edge like that. Now we encounter the hard clot. This is hard clot. It's very difficult to remove it at this moment. So we remove the soft clot first, then we can mobilize the hard clot. Like this. And now we can see the hemorrhagic point at this area. Here is a bleeding vessels. So evacuate the CSF and touch the suction tube and coagulate it. Complete hemostasis was achieved. After that, insert the surge cell inside the hematoma cavity. Small amount is enough. Good removal was achieved like that. Endoscopic ICH removal is a fast and easy technique in most cases. But there are some surgical tips that need to be adhered to for a successful result. So please attend the hands-on seminar before you start. We have a very good hands-on workshop. I hope we will have this workshop next year. Now let's move to the tumor removal surgery. The main concepts are similar to the hematoma removal. But cylinder tumor removal surgery requires several specific techniques. We use neuroport and neuroport mini cylinder and view side tubular retractor as well in this surgery. It depends on the cases. This is how I introduce the cylinder. Endoscope tip is calibrated by the navigation system, and endoscope is inserted inside the cylinder. Translucent test up needle like this. For doing so, we can notice the location of the endoscope tip by the navigation system, and we can get the direct viewing of the cylinder tip like this. And the removal technique inside the cyst is divided into two, one hand surgery and two hand surgery. In one hand surgery, the endoscope and suction monopolar are mainly used. The cyst is held by assistant, and the main surgeon holds the endoscope and other instruments. It is important to change. It is possible to change the direction and operation field dynamically by tilting the cyst, like a hematoma removal surgery. It's very good for the suckable tumors, but it's not so suitable for the hemorrhaging tumor and hard tumors. In two-hand surgery, we use both hands. The sheath is held by assistant as one-hand surgery, and the endoscope is held by the endoscope holder, like this one. It is easy to achieve the precise dissection and hemostasis, and tumor debulking is also possible by using scissors. So this surgical technique is used for the hard tumor, eloquent tumors, and hemorrhaging tumors. But in two-hand surgery, a larger diameter cyst is required. If you use a larger diameter cyst, surgical maneuverability improves, but the surgical corridor becomes large. So it depends on the case. This is our wet field technique. Endoscope gives a bright and wider view even underwater. Underwater surgery, we call this technique as a wet field technique. Can expand the tumor bed naturally. This is a dry field, and this is a wet field. We can expand the tumor bed very naturally without any additional retraction. And it is easy to find the hemorrhaging point like this. So we can perform the hemostasis with pinpoint coagulation. And we can also see the mobile tumors, residual tumors here. We can find it very easily. Sorry. And we use these surgical tools. This rotating movement does not require the shaft movement. So it's very important in the cylinder surgery. And this malleable forceps is also useful in the very narrow cylinder surgery. And this malleable bipolar forceps is useful in the hemostasis. This is a clinical case, 42-year-old female cavernoma cases. We made a 2.5 craniotomy and 10 millimeter cis was used. Insert the cylinder with direct viewing. We can notice the tumor like that. In this cavernoma, there is a solid compartment, so we use scissors for reduce the tumor size. After that, surgical field was filled up with water and dissection was performed inside the cis like that and remove the tumor. Sorry. Complete removal was achieved. And surgical trajectory is minimal like that. We cannot see that. And the skin incision also small. We can perform this surgery for the GBM cases. This patient had a recurrent GBM and he received the craniotomy and chemoradiotherapy, so the skin is very weak. So we performed the keyhole cylinder approach for this patient. We made a 4 centimeter skin incision in the eyebrow and make a 2 centimeter craniotomy and insert the cylinder from here to here. Fortunately, this tumor is suckable, very soft. So we performed a one-hand surgery at this moment. Of course, this tumor is GBM, so there are many feeding arteries inside. So we coagulate these arteries with two-hand surgery, like this. We coagulate every arteries. Now we encounter this part, hemorrhaging part, but we can use the bipolar coagulator. So we'll stop the bleeding. After that, coagulation and suction technique was used. This is the MCA, maybe this part. So we abandon the tumor removal at this moment. After the removal of the tumor, we filled up with water. Wet field technique was used to confirm the complete hemostasis. Good removal was achieved like that. We use the direct cortical stimulation in this surgery. This tumor is located in the relatively eloquent area nearby the motor cortex. So we use direct cortical stimulation. Make a small craniotomy and insert the strip electrode and make a small corticotomy and insert the cylinder. Fortunately, this tumor is also the suckable. Direct cortical stimulation was performed and bipolar suction technique was performed. We removed the tumor subpial fashion. And now I'm removing the tumor in this part nearby the motor fiber. Now we got the response of MEP, so we stopped the removal. We can also use a direct cortical MEP, subcortical MEP in this patient. Now the endoscope resolution is developing, but still the resolution is not better than the microscope. So sometimes it's very difficult to identify the tumor mass. So I use 5-area fluorescence in such cases. We made a 2-centimeter craniotomy, and inside the cylinder like that, we encounter the tumor here and evacuate the tumor mass. This is a 5-area fluorescence. We can see the red color tumor here. This 5-area fluorescence is useful to find residual tumors. Sorry, gross total removal achieved. And I also use the ICG fluorescence in this case. ICG fluorescence is very useful for the enhancing mass. This is a 5-area fluorescence. There is a tumor and 5-area response was seen. This is a tumor mass. We can see the blue color. Enhancing mass can be visualized with blue color, and 5-area fluorescence can visualize a small amount of the tumor with red color. So we can identify the small mass like this. This is my personal experience. I started this surgery from 2013, and I experienced 120 cases of cylinder surgeries. Among these cases, I performed the removal surgery in 75 cases. The pathology is various and location is also various, but recently I performed this surgery for the brainstem lesions, more eloquent area tumors. This is a surgical result. Gross total removal was achieved in 60%, but the removal rate is depending on the pathologies and surgical goals. In the glioma cases, gross total removal is not so high, but still the surgical goal was achieved. So it's not so big problem. And complication rate is here. Mortality rate is 0%, and morbidity rate is 4%. I think it's a acceptable result. So the summary is here. Endoscopic minimally invasive approach for the interparenchymal region with transparencies is safe and effective. Development of surgical instruments will expand the indication of this surgery. In wet field surgery, the surgical cavity is kept inflated naturally, and the 5-area fluorescence, ICG fluorescence, and direct MAP are also useful in endoscopic surgery, like microscopic surgery. Thank you for your attention.
Thank you for this interesting presentation. Suresh, please go on.
Yeah, thank you very much, Dr. Takeuchi, for this nice presentation. And we will start some questions. Okay, there's a question from Kenichi. Let me see.
Sulma had a question.
I can't see the question actually. Henry, can you see the question which has been asked by Kenichi?
Sulma has a question. Please unmute yourself and ask the question.
Thank you. Thank you. That was a wonderful talk. That gave us more challenges. I was just curious about the way that you are able to see the fluorescence, the 5-ALA under the endoscope. Do you use a microscope? Is it endoscopic assisted, or how do you do it under the endoscope?
On the endoscope. In the 5-ALA fluorescence, I use a specific kind of light source, and we put the filter on the scope and the camera head, between the scope and camera head. It's not so difficult. And in ICG endoscope, we can ICG endoscope is available from the Karl stores.
Okay.
Okay.
We don't have all these available for the endoscopic surgery. What about you, Zulma?
I don't have it. I was so curious because
Yeah.
we have it for the microscope, but not for the endoscope.
Not for the endoscope, correct. Okay, any other question?
Yeah, there's another question. For bimanual dissection, what is the size of the instruments in tubular retractor?
It depends on the cases. If the tumor is not hemorrhagic, I use a 6 millimeter cylinder. If the tumor size is less than 3 centimeter, we can perform the removal procedure within the 6 millimeter diameter cyst. But the tumor mass is larger than the 3 centimeter. I use 10 millimeter or 12 millimeter cyst because the removal procedure is time consuming. So I recommend the larger diameter cyst for the larger tumors.
Okay, for the deep-seated tumors, how do you choose the entry point? Do you choose for the deep-seated tumors, very deeply located tumor? How do you choose the entry point? How do you enter this?
For the eloquent tumors, so I always perform the MR-DTI. Right. So the neurofiber is the most important thing in this surgery. So I perform the MR-DTI before surgery.
Okay, just because you didn't mention in your talk. Anyway, there is another question from Professor Muthukumar from India. Was there any occasion when you had to convert to open surgery because of bleeding or inability to completely remove the tumor?
I've never experienced switching to the microscope, but if the severe hemorrhage occurs, I always think about switching to the microscope. But in most cases, we can change the cylinder size. It's very easy to change the cylinder size. Just insert a larger diameter cyst. So it's not so big problem.
Okay. Arthur can just unmute himself. Is Arthur online? Anyway, there's a question from Arthur. He says there were some cases that was necessary to move to open surgery. Oh, the same question. How large is your trepanation? How big is the opening you make?
I usually perform the 2.5 centimeter craniotomies. Because that is because smaller diameter craniotomy makes difficult to change the direction of the cylinder. But if the craniotomy size is large, the cylinder is not stable. It's very difficult to control the direction. So I think 2.5 centimeter craniotomy is best for the cylinder surgery.
Okay, good. Yeah, Ulrich.
I have
Yes,
a question. Thank you very much. Congratulations for this technique. That's really amazing. What about purely intraventricular tumors? Do you use the same technique?
Yeah,
Yeah.
I use the same technique. It's
And
not so
any
difficult.
restrictions or any technical nuances for intraventricular tumors? Because it's I think, a little bit different approach.
Yeah. I usually use the wet field technique in the ventricular tumors because if evacuated CSF, the ventricular size shrink, so it's very difficult to control the cylinder. The cylinder edge is a little bit sharp, so we can easily to damage the ependema. So I want to expand the ventricular size. So I usually use a wet field technique in the ventricular tumors.
Can I just
Right.
ask one? I think deeper tumors, I understand. Once you decide the trajectory, you can probably go ahead. But you showed one tumor which was almost coming up to the surface. There, how, I mean, what is the logic of putting a cylinder in that kind of a tumor where you did motor evoked potential to begin with, and the tumor was coming all the way up? So, you know, it would be on, it would probably just spread outside the cylinder.
So it's you want to talk about the cylinder size?
No, I just wanted to know, in a superficially located tumor, just a subcortical tumor, how
Yeah.
effective is the cylinder, and can it be easily or safely used?
Yeah, I want to of course, a very shallow tumor does not require the cylinder surgery. Of course, normal keyhole surgery is enough for that kind of patient. But if the parenchyma is covered the tumor, even the normal brain parenchyma is small, I use a cylinder because a normal brain shrink down to the tumor bed. I want to keep it outside the cylinder, so I think it's effective.
Okay.
Okay.
Thanks.
So there is another question from Dr. Lokendra Singh. When you put your cylinder into the brain, do you open the sulcus and then negotiate the cylinder, or you do a cortisectomy always?
So transsulcular approach or a transcortical approach, you mean? I prefer transcortical approach because some doctors perform the transsulcular approach, but in the sulcus there is many arteries and veins. I don't want to injure such kind of arteries. And maybe the transsulcular approach is safer for the U fibers or something like that. But I don't think it's not so safe for the surgery.
Okay, fair enough. Right. Any other question? About the intracerebral hematomas, can I ask you one question, Dr. Takeyoshi?
Yeah.
When you have a hematoma which is partly in the parenchyma and partly intraventricular and causing ventricular dilatation to some extent, how would you put your approach? It will be transventricular or transcortical? How do you evacuate the hematoma?
It depends on the location of the hematoma. and the shape of the hematoma. So I
Okay.
can't clearly say.
Yeah.
If the hematoma component inside the ventricle is large, I perform the ventricular approach.
Okay.
Okay, thank you, everybody. I think we continue now with the questions. Did all participants get the question, Imad? I think everybody should give a response to the questions. But I don't know how.
Don't see any question.
So Imad is showing the questions, but I don't know. Usually you should have the opportunity to click on it.
Yeah. No, I don't think you can click it now.
No, you have to open it on the Google form. But maybe I think no one of the participants had got the questions in time. So I think it's best you read your question. Sulma, I think it's your question, and then you can give the explanation what is correct.
Well, I mean, this is pretty basic, right? Diagnosis of ventriculitis is made by CSF gram stain and culture, clinical evaluation, MRI, none of the above, of all of the above. Easy peasy. So obviously all of the above.
So actually the question is not framed properly. D is not the correct answer. Is that right? When you say all of the above, means none of the above also there. Okay, move.
Correct.
I'm
Let's
just a brain surgeon, Suresh.
Let's move on to the next one.
The best sequence to diagnose ventriculitis and MRI is? I said that like 3 times on my talk. Anyone? Diffusion weighted images. And endoscopic lavage for ventriculitis, A, improve outcomes, B, make treatments longer and expensive, C, increase the number of shunted patients, D, increase morbidity and mortality. Ulrich, I can see your face.
Just the positive.
Just the positive, right? A. All right. That's your Ulrich.
Okay. What kind of solution is used for neuroendoscopic lavage in neonates? Of course, we discussed this, but you always get the questions when I give my talk. So it's not isotonic saline solution. Artificial CSF would be perfect, but it's not available everywhere, only in Japan, I think. A lactate-free ringer solution is the best practical solution to get it maybe in every country. Lactate solution would involve the pH too much, and isotonic sodium bicarbonate is only an additive if you use lactate ringer solution. So the correct answer is D. The next. So what procedure, this is the question for the neurosurgeon Suresh, I think, because what procedure are usually recommended during neuroendoscopic lavage in neonatal IVH from the following list? ETV, septostomy, aqueductoplasty, or choroid plexus coagulation.
So I think septostomy alone.
Septostomy alone, right. Of course, I know that in Brazil they do ETVs and also choroid plexus coagulation as well. So it's debatable, but still, I think it's the safest just to go for the simple one, which is needed, and this is septostomy.
You forgot the option of depends on how eager the neurosurgeon is.
Yeah. Okay, and this is just to remind you to take more interest and active participation in the trophy registry. So who knows what is the right URL for the registry? A, trophy.ifne, trophy-study.de, trophy.org, trophy-registry.org, or neuroendoscopiclavage.com.
D.
The
D. Correct.
D sounds best.
D is the, like Dora,
yeah.
is the correct answer. Trophy-registry.org. For everybody who doesn't know it, now you know. So go and register today. Thank you.
All right, next one, hematoma.
Which is the most appropriate position and the whole location for endoscopic removal of the hematoma in cerebellum? Select 1 or 2. The answer is A and D. The important thing is cylinder direction. If you put the patient like B or C, put the prone position and face facing down, and retrosigmoid area butthole, the cylinder direction is horizontal to the floor. The hematoma come out to the cylinder. The endoscope can easily fog over by the hematoma and obscure the view. It's very dangerous. So I don't recommend that. C is also like that. So A and D is a correct answer. Okay. And in endoscopic cylinder surgery for glioblastoma, which of the following techniques is utilized? Select 1 or 2. The answer is B and D. In the malignant tumor removal, dissemination is serious concern. So if the wet field is used in the early stage of the removal, dissemination may be occur. So removal the malignant tumor with a dry field is recommended. But after the removal, hemostasis is also important. After removal of the most part of the tumor, wet field technique can be used with low disseminating risk. And maybe first question is exists?
Anesthesia.
Anesthesia.
Mark, the first question, can you go back 2 questions? We missed one.
First one.
First one.
No. Question cancelled. Maybe you read it, Lai. Takeshi,
Okay.
just read the question.
Which anesthesia is appropriate for the endoscopic hematoma removal surgery? General anesthesia, local anesthesia, or anesthesia does not matter? Answer is A, general anesthesia. In terms of the pain control, endoscopic hematoma removal only requires small skin incision and small burn hole. Local anesthesia is enough, but patients sometimes have nausea, vomiting, and some sudden movement due to the low consciousness level. So it's a little bit dangerous. General anesthesia is much safer.
All right.
Okay.
Okay, thank you everybody for this 10th webinar. I think it was an interesting topics which we covered, and I thank all participations and all speakers and my co-moderator. And of course, I want to thank Imad from Pakistan, who made this event possible, although they have the Spine Congress. It is very nice, and we thank everybody. Chandra, do you want to make some comments? Is Chandra still with us? Or you had too much rain in Mumbai and is gone? Suresh, then please give the last words.
No, it's fine. I think this was a wonderful webinar, and we really learned so many new things from all the speakers. And I really thank you very much. My thanks to all the speakers and the IFNE. The president is here, and I would really like to thank the IFNE to start this webinars, which we have reached halfway through, correct? And we have a few more webinars yet to come. And we are learning every day, and would like to thank everybody for who have contributed in this webinar series. Thank you very much.
Thank you so much.
Boba.
Thank you very much, everybody. Nice seeing you.
Hope to see you in 4 weeks for the next webinar. Thank you. Bye-bye. Nice weekend.
Thanks.
Bye-bye, Wiedersehen.